welcome all to our policy and inclusion debate series. This is being co-organized by Center for Equity Studies, by Rosa Luxemburg Stiftung, South Asia, and by NewsClick, our media partner. So friends, the topic of the webinar today, that's vaccine inequality and the neoliberal order. This seems particularly pertinent to our times because as India stares at the specter of a possible third wave, and there are cases rising across Europe and different countries and several other countries as well. So what is seeming like is that at the global level there is perhaps a reluctance, or we have seen issues of a reluctance to share technology, to share know-how, even to distribute vaccines. And what we witness is that there is excess of vaccines in certain nations, that they are having to either dump it or dispose it. And then we also have a figure of 1% for the poorest countries, where only the 1% of the population is vaccinated till now. And whatever we have seen in the last 1 year is that the lesson which the pandemic holds is that we need to understand that this is something which we face as a global community and as a national community. But what it seems perhaps is that through all these inequities which we see at the global level and also at the level of, say, for instance, in India, where owing to poor planning and a reliance on a technological platform and a will to make sure that private companies profit at all times, we see that there is gross inequity in vaccine distribution amongst nations and within certain countries like India. What seems is that there is, apart from a faulty decision making, it seems that the political class is acting within certain global structures, and which is the neoliberal order which we have witnessed. So on this urgent issue, we have an illustrious panel with us, and they will not only explain the details of the problem, but also point towards possible solutions at this point of time. So we have with us Dr. Anand, who is a senior lawyer known for legal activism in Indian law relating to homosexuality and HIV. He's a founder member of the Lawyers Collective. He was also the United Nations Special Rapporteur on the right to health. He's currently a member of the Global Commission on Drug Policy. Then we have Dr. Gagandeep Kang, who is a professor at the Department of Gastrointestinal Sciences at the Christian Medical College, Vellore. She has previously served as executive director at the Translational Health Science and Technology Institute, which comes under the Government of India. She also serves as chair of the WHO's Technical Advisory Group on Immunization for the Southeast Asian region. And she is also on the WHO Advisory Committee for Vaccine Development. In 2019, Dr. Kang became the first Indian woman to be elected as Fellow of the Royal Society of London. Then we have Professor Jayati Ghosh, who is a professor at Department of Economics, University of Massachusetts at Amherst. She has also taught at the Center for Economic Studies and Planning at JNU for almost 35 years. In 2021, she was appointed to the WHO's Council on Economics of Health for All. She is also among 20 prominent personalities appointed by the UN to a high-level advisory board that provides recommendations for the UN Secretary General to respond to the current and future socio-economic challenges engendered by the COVID situation. Then we have K. Sujatha Rao. She served as Union Secretary, Ministry of Health and Family Welfare for the Government of India until 2010, where she was involved in the first ever national program for non-communicable diseases. Previously, Sujatha Rao was Director General of National AIDS Control Organization, where she was instrumental in establishing systems and building up NACO with a capacity to implement programs with a 5-fold budget increase. She has represented India on boards of the WHO, Global Fund, and UNAIDS. Then we have Professor R. Ramakumar, who teaches at School of Development Studies, Tata Institute of Social Sciences, Mumbai. He has been a non-ministerial member of the State Planning Board, Government of Kerala. And Professor Ramakumar has been a vocal advocate of free vaccines and consistently wrote about inequities and disparities in India's vaccination program. So now I would request Harsh to take the proceedings further. Harsh will be moderating the webinar. Thank you.
Thank you so much, Amitanshu. Just a quick word that it's such an extraordinarily accomplished panel. The least of their qualifications is that most of them are dear friends. But much more than this, I don't think we could have a finer set of people to speak on, just for sheer survival, perhaps one of the most critical questions that the world is facing at this moment. Um, uh, I won't say very much because we have great panelists to listen to. Just a few things in the beginning. I think that among the lessons that this pandemic should have taught us, it is that no one is safe until everyone is safe. And yet, vaccine policies, both at, in between countries and within countries, seem to be entirely geared, in my understanding, on the one hand, to ensure the separate protection of the wealthy within countries and the wealthy nations in the global family. And the other is to preserve private profit and to, and the public good seems to be, badly lost in all of this. Um, uh, the statistics are important, but what is going to be the cost of these mistakes is not only going to be borne by the poor. This is probably the first major global pandemic which actually hit the rich first, rich countries and the rich within countries, and then came to the poor. But like in everything else, the burdens of all the mistakes that we're making is going to be borne most by the poor. But in the end, because no one is safe until everyone is safe, by leaving out the poor, everybody is putting themselves at risk. Oxfam reported, there's the People's Vaccine Alliance. 77 epidemiologists from 28 countries were interviewed. And 2/3 of them thought that we have less than a year before the virus mutates to an extent that the majority of first generation vaccines will be rendered ineffective and new or modified vaccines will be required globally. We need to stop and think what this means. This means that if we are not able to vaccinate enough people around the world, we will probably be drawn. We can be drawn a good. There's a good chance that we'll be drawn into a situation where actually we'll have to have whole new research on new vaccines, and it'll take months before they are approved for use, longer to begin rolling them out. Lockdowns and travel bans will continue, and this may be part of our lives. New vaccine recipes in the end, if we don't make changes, will be subject to the same pharmaceutical monopolies, further restricting access for around the world. I don't know where this vicious cycle will end unless we really fight for greater equality for the sake of the disadvantaged and for the sake of all of us. The solutions which we'll be talking about seem to have to be the open sharing of technology and intellectual property, which could increase global vaccine coverage, the lifting of pharmaceutical monopolies, the sharing of technology to urgently boost vaccine production, because one of the other cliches that are so important to are so truthful, that viruses don't care about borders, and we have to have a solution that also pushes borders between countries, but also within countries. India's policy, we'll have occasion to talk about, I think, is a classic example of how exclusion is built in at every stage of the policy making. And we still are one of the only countries where people have to pay for vaccines. We still have reserved 25% vaccines for the private sector. And ultimately, that means that it will allow the rich and the middle class to break the line, get vaccinated, and feel safe. Because if it's 1,000 rupees, 5,000 rupees a family, for one 10,000 rupees for 2 jabs, it's not something that many families in this country can afford. And so once again, we seem to be preserving the interests of the elite and private profit, and squandering the opportunities to protect the lives of all of us. So I won't say more. We have a very fine panel, as I said, to reflect on all of these questions. Just for the audience, we will be going in 3 rounds. I will be asking 2 separate questions. And after that, we'll have 1 round, which my dear friend and colleague Navsharan Singh will moderate, where we will be taking on questions from the audience. Those of you who are on Zoom, please put them on chat. And she will be trying to compile the questions. And the last round will be responding to audience questions and closing remarks. So my first question, the first round, I wanted to understand the nature, the extent of vaccine inequality, as I said, between nations and within nations. What has caused this? How much of this is linked to public policy? How much of it is linked to the larger political economy of neoliberalism? In simple language, as I said, the defense and the upholding of private profit and intellectual property rights and pharmaceutical monopolies, and what is going to be its public health consequences. That's the first round. We'll be looking towards solutions in the second round. So I come to our panel. Let me start with the very globally respected public health epidemiologist that we have with us, Dr. Gagandeep Kang. And so why don't we hear you to open up the discussion, please.
Thank you very much, Harsh, for inviting me to be here with you today. And I think to start with, I'd like to reflect on a little bit of public health history. So if we go back, and not too far back, to what happened with H1N1. Now that's a virus that we are familiar with. We know how to make vaccines for that virus. It's possible to make those vaccines within 6 months or less, because we make flu vaccines all the time. And when we got the H1N1 very quickly, it was possible to grow the virus. WHO was able to distribute the virus to multiple manufacturers and ask them to make vaccines. WHO actually at that time did think about the poor and disadvantaged in the world and set up to have a system where vaccines could be donated to WHO and distributed to poorer countries. What ultimately happened was that rich countries got their act together, made their vaccines very fast, and then vaccinated much of their own populations, and very late and in very small quantities donated a little bit of vaccine for distribution to LMICs. And essentially, it wasn't enough to make a difference at all. We were really, really lucky that H1N1 was not the killer flu. we actually then had another virus, which was a killer virus. And again, we knew how to make vaccines. This was Ebola in West Africa. We had known about how to make vaccines for Ebola since the early 2000s. There was a vaccine made by the Public Health Agency of Canada, contracted to a company in the US, and that company never made the vaccine because Ebola only happened in West Africa. It happened in small villages. It affected a few hundred people at the time. You could quarantine a village and the disease would burn itself out. Everybody who was going to die was going to die. Then it came into urban West Africa. And now instead of hundreds of cases, you had thousands of cases, and you had them in places with airports where the disease could actually travel. And then the world started getting into the act slowly, discovered that there was this vaccine, and decided to put together global efforts to make those vaccines. Who did they go to make the vaccines ultimately? Well, the two licensed vaccines are from Merck and Janssen & Janssen. It took about 7-8 months to get their acts together, to carve up the 3 countries that were affected by the pandemic. One to have studies by WHO, another from the CDC, and another from the UK. So in some senses, it was interesting to watch the politics play out as rich countries decided that they had to do whatever they needed to do to keep the disease from reaching their shores. In response to Ebola, there was a new organization that was set up called the Coalition for Epidemic Preparedness Innovations. It was established based on a call that was put out by Jeremy Farrar, Stanley Plotkin, and somebody who had been at Merck previously leading their vaccines division. And the idea of CEPI, and I always worry, I'm vice chair of the board of CEPI, but I always worry about the fact, is this another Ebola? Is this another exercise where you have investments made in vaccine manufacturing that allow for rich countries to protect themselves from the diseases of the poor? So, but CEPI was established to deal with making vaccines quickly and distributing them to people without worrying about whether they had the ability to pay. So bring the best science, have lots of vaccine candidates, focus on diseases that cause epidemics in developing countries. So a worthy cause. And as it turned out, a very valuable investment, because it funded mRNA vaccines, it funded virus vectored vaccines, and it wound up essentially being one of the central pillars of the COVAX facility. Now, I'm the chair of the Equitable Access Committee for CEPI. And throughout, what we have tried to negotiate in every contract is a line of sight to access. How do you make sure LMICs have access? It's obvious by now that CEPI's contracting mechanisms did not assure access to low and middle income countries. And the reason for that, I think, are 2. One is rich companies that make a lot of vaccines from developed countries don't participate in efforts like CEPI, and we can get into why large vaccine manufacturers don't make vaccines that have a high chance of failing. And the second is CEPI was very good at developing vaccines, but it's not the purchaser of vaccines. So if you want to influence the access agenda, you really need to have the money to buy vaccines, whether you are a government or a non-governmental organization. So I hope that helps set the stage, and I'll come back later with why we think we failed.
Thanks, Gagandeep. I think that was a perfect start to help us understand, and how little we learn from our histories is something that keeps coming back to us during the mishandling of this pandemic. Sujatha Rao often mentions about, we have an experience, very, very strong experience of dealing with epidemics, global epidemics, the AIDS, and so much, but we still don't learn. Let me come to Dr. Ramakumar, Professor of Development Studies from TIST, and very, very strong voice for free vaccines for all. So, Ram, would you like to come in with your observations next?
Thank you, Harsh. I was expecting that I would be called towards the end and I would be able to pick up a lot of ideas from others, but you probably don't allow that. I think because of the shortage of time and because I'm sure others will also speak about many of the things I would want to say here, I would like to make 3 or 4 major points only. The first point is that India is currently an extreme laggard in terms of vaccinating its population. As of yesterday, we have vaccinated only about 22% of our population with the first dose and about 5% of our population with both the doses. And that compares very poorly with the 55% of USA or 70% of Canada, or 60% of Italy or 58% of Germany, and so on. So we are clearly a laggard in this. What is the context in which we have to understand this poor performance of India in vaccination? The first point that I would like to make here is the failure of vaccine planning and vaccine policy of the government of India. The Prime Minister had announced on the Independence Day last year that we are not making 1, we are not making 2, but we are making 3 vaccines in India. And he added that capacity expansion plans are ongoing on a war footing, and we are putting all our efforts and investments into capacity expansion in the production of vaccines. Almost an year has passed, and we still we need about 55 to 60 lakh doses per day to be regularly administered in India, but our average is somewhere between 35 lakh to 40 lakh per day and not more than that. Our production capacity has not increased beyond that. What are the major reasons here? There are 3 major reasons for this. The first is that India failed in diversifying its vaccine basket, both in terms of the number of products and in terms of the technology platforms that are available worldwide. We all know about the absence of consistency in policy here, where Covishield was given permission, but not Sputnik. Covaxin was given permission, but not Pfizer, and so on. The policy that was preferred put politics on top of science or reason. It was put forward that the Atmanirbhar policy or the Made in India vaccine policy would take care of not just India's requirements, but also to position India as a Vishwa Guru in the world vaccine sphere as well. So very clearly it was politics that made this policy and not science, not reason. That's the first point I wanted to make, the first point of failure. The second point of failure is, while most countries of the world made huge at-risk investments in vaccine research and development as well as manufacture, India completely failed in making any significant investments in this regard. We know the investments of the US government in Moderna, or German government in BioNTech, the British government and other national institutes of health in Oxford vaccine, and so on. We have not seen a similar effort coming from the government of India at all. The third important aspect of failure is the inability of the government of India to place advance purchase orders in time. While a country like Bangladesh placed its order in November of 2020 itself, and most other countries had made it by June 2020 itself, India's first order was made only in January of 2021, that too for a paltry 6.6 crore vaccines. So these were the 3 aspects of failure that acted as a context to the extraordinary shortage of vaccines that struck India after the 7th of April, when daily vaccination rates fell from about 50 lakh to 52 lakh per day to something like 18 to 19 lakhs per day. That's the kind of a fall of vaccination rates that we had. Now, it is in this context that the government of India changes policy into what it called as the liberalized vaccine policy, where the rather disastrous 50-25-25 division policy was announced on 19th April with effect from May 1st. Here, there are two important points to note with respect to this policy shift on 19th April. One is with respect to its economics, whereby the government of India literally succumbed to the pressure from vaccine producers to earn super profits. Adar Poonawalla has been quite open in his demand for super profits in this regard. Krishna Ella, who at one point of time said that my vaccine would cost less than a bottle of water, later said that I want a maximum price for my vaccine. So the government literally succumbed to all these pressures and allowed vaccine companies to triple and quadruple prices by the last week of April. The second important aspect of this 19th April policy was political. The central government did not want to take up the burden of the burden of political costs with respect to vaccine shortages, which were clearly expected to grow after April. It wanted to blame the states for vaccine shortages. Instead, so if 25% is given to states and 25% is given to private hospitals, in the face of vaccine shortages, the blame can be passed on to state governments, and the prime ministers and the central government's image could be kept intact. That was the second important feature of this policy. But this policy very clearly failed in a very bad way. Daily vaccination rates, as we know, fell from 29 lakh per day in April to just about 19 lakh per day in May. States could not procure vaccines. The center said that states and hospitals could procure 16 crore vaccines between May and July. They were not able to procure more than 4 crore vaccines as per what the data shows. Now the policy has been aborted anyway. Private hospitals, they were given freedom to buy, but news items appeared which said that 50% of the vaccines procured by all private hospitals were cornered by just 9 large corporate hospitals in the country. So there was extraordinary failures in terms of not just production and distribution, but also in terms of the inequalities that emerged in the way vaccines were distributed among different sections of the population. Very clearly, then, the policy of liberalized vaccine policy was a failure. Now, this was the context in which the Supreme Court intervened. Chief ministers started writing letters, particularly the Kerala Chief Minister tried to bring together 11 chief ministers to create a broad argument for free and universal vaccination in the country. It was in this context that the government withdrew from it. It has now settled for a 75-25 policy, but 25% continues to be reserved for private hospitals at very high prices, 1,380 rupees for Covaxin and 780 rupees per dose for Covishield, double of this for 2 doses, which basically would take away half the monthly income of a household at the poverty line for one person getting vaccinated fully. Now, this primarily means that the 25% that is kept for private hospitals is essentially a reservation of the vaccines for the rich of India. And this is one of the most important continuing elements of inequity in the vaccine policy in India, even though it has been partially revised with effect from June 21st. The second important point note here is this 25% vaccine doses given for private hospitals is being utilized also to organize enormous vaccination scams in the country. In city after city, you see thousands of people being vaccinated, sometimes with glucose water, sometimes it is argued that they were rabies vaccines and so on, we don't know. And all these are basically coming in from the 25% quota allotted for private hospitals. Now, for full equity to basically come into this policy, this 25% quota of private hospitals should also be disbanded. 100% procurement should be undertaken centrally by the government of India and distributed freely and universally to everyone in the population. My 7 minutes are actually over. I would not want to extend this conversation, but I would be happy to make the rest of my points when you ask the next set of questions. Thank you very much.
Thank you so much, Ramakumar. I think we we got a very sort of magisterial span of the issues at the national level. We are sort of, fortunate to have one of our finest economists, Jayati, with us. But Jayati's, could have spoken about the situation within the country and the inequalities within the country. But she's part of the WHO Council, and I think that we request her to once again talk about the inequalities between nations.
Thank you, Harsh, and it's a great pleasure to be in this panel. I also learned a lot, I think, from Gagandeep Kang's presentation just now, and I'm going to follow on from that because I think it really captures the essence of what is going on. The past is unfortunately a very good indicator of our present, and this is something that was already feared as long back as mid-2020, when the People's Vaccine Alliance started getting very concerned about the inequalities that were likely to occur with vaccine development and distribution. I think Gagandeep has already talked about, the basic pattern that we have seen over and over again, with rich countries promoting their pharma companies to actually produce vaccines, which they then keep for themselves. This was very, very evident, as we have seen here. And there have been a couple of things that have really added to the massive inequalities in vaccine distribution that we see today. Till last week, 75% of vaccines had been administered in just 10 countries. And as you have mentioned, large numbers of countries, the low-income countries, about 1% there are still some countries where there have been no vaccines administered at all. And of course, there are egregious errors within distribution internally, as Ramakumar has already pointed out, but there is a global problem. And that has to do with a number of ways in which the system itself, if you like, has been designed. COVAX, for example, I think it's already been mentioned that COVAX is massively underfunded. Its own estimation is that it would have needed about 24 billion in the first year. It's got 6.2 billion so far, which is ridiculous. And this is not even 0.1% of the kinds of stimulus packages that are being done in the US and the European Union. So it would have cost them next to nothing to fully fund COVAX. But there was an inherent design flaw, which is that COVAX enabled states to go in for side deals with Big Pharma. And so the governments that had promoted Big Pharma to undertake very, very rapid development of these COVID-19 vaccines went in for side deals. Other governments also did. It was opaque. We've had all kinds of differential pricing. We know that many developing countries are now paying double what the EU has paid for both Pfizer and AstraZeneca. So it's quite extraordinary the ways in which COVAX was not only underfunded, but it could not buy the vaccines because others were grabbing. We've had the Canada order as much as 11 times its population's worth, the US 4 times what it needs, and so on. And of course, as a result now, even with the vaccination drive in these countries slowing, you have massive stockpiling. And the US is still sitting on 80 million doses of AstraZeneca, which it is distributing in dribs and drabs. It's never going to use them. Vaccines are being delivered to African countries 3 weeks before the expiry date, which really means they can't be used by the time you get all the systems organized to, it's maybe 1 or 2 days before expiry date, and then vaccine hesitancy will obviously dominate in such circumstances. So the vaccine apartheid that we've seen is partly due to the fact that the design of COVAX enabled this kind of vaccine grab and vaccine nationalism by developed countries. But then there is the other very large issue of production. And obviously the big issue is that the supply of vaccines is not adequate, right? It's not enough. Why is it not enough? 2 fundamental reasons. The TRIPS Intellectual Property Rights Agreement of the WTO, which prevents, or shall we say restricts, the capacity for compulsory licensing within developing countries or anywhere else in the world because of the range and complexity of the kinds of compulsory license that you must issue. The mRNA, there are 64 patents involved in the process of making the mRNA vaccines. So, the kinds, it would take very, very long time to issue compulsory licenses for all of them. So the TRIPS waiver is really just a legal, shall we say, necessary condition It's not sufficient, I'll come to that, but it's the legal necessary condition. Here, I would also like to point out that there's a deep contradiction in the Indian government's policy. It is with South Africa, it brought in the case against or for the TRIPS waiver in the WTO. It has not issued compulsory licenses even for Covaxin, which was done with ICMR support, and which it could easily have done without facing any of the other issues that are inherent in TRIPS. But this is just the legal precondition. You obviously have to get companies to share their technology. And this is where it would actually be relatively easy for a number of developed countries, governments, to force the big pharma to share technology. Because this is almost entirely publicly funded. I'm sure, Gagandeep Kang will know much more about this, but we know that the US government gave $12 billion to just 6 pharma companies. And Europe, similarly, Germany paid BioNTech. It's paid a number of other companies. AstraZeneca is 95% public research done in Oxford University, entirely publicly funded, handed over to AstraZeneca after the Gates Foundation intervened. So they could easily push their companies to share the technology. The Biden administration already did this with J&J. It said, share your technology with Merck, but again, only for domestic production and distribution. The WHO has a system, the COVID-19 Technology Access Pool, for the sharing of technology. None of the big pharma companies has joined. A few developing country governments have joined, but that's not much use because they don't have the technology. So we definitely need for these governments to be pushed to push pharma companies to share the technology, and it can be done. I've talked about the issue of stockpiling, but there is also the issue of the supply chains. A lot of the intermediate inputs and other raw materials required for these vaccines are held in particular countries. The Biden government still has an export ban on many of these. And so these also are in short supply. So there are many things entering into this whole process. Vaccine apartheid is now going to be even further advanced by the fact of vaccine passports, which many governments are promoting. And of course, it's only the WHO approved vaccines that will have access to the vaccine passport. Here too, the regulatory process is much longer for vaccines that are not developed in those countries that are of stringent regulatory authorities. In other words, not US, Europe, Australia, Canada, Japan. Other than that, every other country has to go through a much longer process. I'm not sure about the medical issues, but it's definitely also a much longer bureaucratic process to get the approval, which means that, let's say, Sputnik 5 still doesn't have approval. Sinopharm and Sinovac have recently got approval, but a number of other vaccines, it will take much longer for them to get that regulatory approval. So we are going to see this continue. And as you mentioned at the very start, it also means that the possibility of new mutant variants, the need for at the least booster vaccines, all of this is going to become more intensified. And it means that there would be no immediate end in sight, or maybe not even a medium-term end in sight, until we can dramatically change these preconditions. Final point, all of these conditions can be changed, and I will talk about that later on.
Thank you so much, Jayati. That was, I think along with Gagandeep, we got a very, panoramic span of what's happening and why it's happening. I come now to Sujatha Rao. She's arguably the most respected public health policy thinkers and actors in the country. And if you could really pick on from, I think, Ramakumar's analysis of what's gone wrong in this country. What's gone wrong with India's vaccine policy?
Thank you, Harsh. I think Ramakumar really dealt with the whole policy, development and evolution rather exhaustively. So I have, frankly, very little to contribute. In fact, all my points have already been said by everybody. So next time I'm going to join your webinar only if you make me the first speaker.
Okay.
So there's really between Gagandeep and Jayati and Ramakumar, I have very little to add, but nevertheless, I'd just like to say that, since you want me to focus on India's vaccine policy, the two areas I think where the inequity comes out very starkly is the fact that, besides the 25% was a clear giveaway that the government was completely pro-farmer and less concerned. It's a bit of a harsh statement, but it's a fact, less concerned about its own citizens as it was to help pro-farmer. And they hid that agenda by saying that the private sector should also be involved. Nothing stops central government from procuring 100% of the vaccine and involving the private sector. No one ever said that only government will deliver the vaccines. Even in the first round, the private sector was given the vaccines by the government, and they were allowed to charge the administrative fee of 250 rupees. I think from all my information, it worked pretty well. And that could have continued. I mean, the 250 was found so reasonable that I know a lot of domestic, servants and all also going for the ease and quickness to go to a private hospital and get their shot and pay 250 because they didn't really hurt. But it's hurt now when they have opened it up for the private sector, both in terms of trying to help the pharma companies as well as the private hospitals. But frankly, the private hospitals don't really make an awful lot of money. They can only charge 150 rupees. You might say it costs 75 rupees and they're making a profit of 75. Frankly, I don't really care. That's a peanut. But what is really bad is the way in which the vaccine companies were given a blanket check to make huge profits. And I think that is a very insensitive and rather disgusting policy that the government of India has taken, because had they procured the whole 100% and allowed districts to make micro planning and allowed the governments, the state governments to carry out the vaccination program the way they have done for polio and for other UIP, I think a larger number of people would have been covered by now than focusing it on metro cities and a few urban areas where the private sector capacities. Even in the private sector, there's an inequity, not just the 9 hospitals, but all the small and medium hospitals could also not have the money to buy upfront from the pharma companies at that cost and then wait for selling, because they knew that in the areas where the small and medium hospitals are located, they're tied to cities and so on, there's that kind of purchasing capacity is not there. So who in those poor areas like can afford to pay 2,500 per head, which is a whole month's wage probably per capita, and get themselves vaccinated? And they know that, and the vaccine hesitancy is another issue, of course, but even if the hesitancy factor was not there, the paying capacity wasn't there, and they knew they didn't have the clientele. So you have really taken the vaccine, 25% of it, as somebody said, reserved it for the middle class in urban cities and metros in particular. That inequity is very clear. And the second part of it was that the government of India gave up its own very well-designed prioritization based on epidemiological data. When it first round, it said all the people with comorbidities will be covered. And then right now that has been given up. So the hardly 50% of the elderly are covered as on today. So should a wave 3 come, I don't know what will happen to these elderly populations, and particularly if they have comorbidities, the deaths might still be, we might still see a lot of deaths, we might still see a lot of hospitalization, because the vulnerable sections of people who ought to and could have been protected by the vaccine were not prioritized in the design. And the design was really flawed when they made it very clear that vaccine would be available only for those who got registered in COVID. I mean, in which world was Mr. Arish Sharma living in? I really don't understand. Which world does our government of India policymakers live in? I really don't understand. How is it that they don't know that there's a whole digital divide in our country. They haven't even been able to, in the last 1.5 years, come up with a credible education policy where they could have covered all children with simple class 1 and class 2 maths or English lessons or whatever lessons they have to go through by using the cell phones. And when they know that there is that digital divide, where does suddenly this COVID business come from? Except to, the impression I get is somehow, anyhow, if we can cover 70% of our population, get that magic herd immunity, it doesn't really matter if the poorer people, the rest of them are poor people who are left out. It doesn't really matter. But then the disease doesn't work that way. So I'm afraid in the entire design of this policy, the rural poor have been the most disadvantaged. Women, as more data is coming out, there is a gender disparity. Women have been disadvantaged, and the elderly have obviously not been covered. And I can very well assume that these are the elderly poor, again, living in rural areas, perhaps not even able to get to the vaccination center. So these are a bunch of policy initiatives. In the policy design itself, I see inbuilt inequity systems inbuilt into the policy design, which are getting corrected, but they should not have been there in the first place. That's my argument. I'll just end with one more, and that is the supply side. I don't know about compulsory licensing or not, but the point is, in May last year itself, we knew that vaccine was going to be a very important intervention in our policy to contain this disease. We knew it. And why we didn't think of our private, for our PSUs. I mean, Chengalput, for example, huge amounts of money have been invested by the government of India. Very good facilities have been set up. Even as recently as a few weeks ago, the Tamil Nadu government said, please hand over that facility to us. We will try and manufacture vaccines. But the government of India won't allow manufacturing there, nor allow it to be given to the state government to manage. I mean, this dog in the manger attitude of ensuring at any cost, whether it's saying no to Pfizer, whether it is saying delaying the Sputnik, whether it is not allowing, Bharat Biotech came up and said, I'm willing to give my technology free. Yes, I know. I think Dr. Gagandeep can easily explain to us that it's not such an easy technology that it can be replicated very easily by every lab. But still, there could have been a strategy drawn up where labs could have been readied for manufacturing this vaccine, and the other labs could have been readied for doing the fill and finish and multiplied our production base. We didn't do that. And I don't think it is oversight. I think it is a deliberate policy to create a monopoly control on vaccine. And I think, basic economics, all monopolies are only trigger inequalities in a much sharper way than anything else. So both on the production side and supply side, it was ideology and politics driving the vaccine policy, not concerns of equity or fairness. So I close with that.
Thank you, Sujatha. I think that was very powerfully said, that what we see as failures actually reflected a very different set of priorities, who you're trying to protect, who you're indifferent to, whose interests you want to protect and who you don't. And therefore we see otherwise baffling policy decisions, one after the other, which has led to a situation which Ramakumar described, where we still have covered too small a proportion of our population with vaccination. I finally come to Anand Grover. Anand was, among other things, the UN Rapporteur on the right to health for several years. In the light of this idea of a universal right to health, where does the world and India stand at this moment, Anand?
Well, thank you very much, Harsh. It's a pleasure to be amongst the stalwarts on public health. A lot of the points have been made. I'll try to pick up on some of the things and actually introduce some things which I think are important. First of all, I think it has to be noted that in terms of constitutional imperatives, there's an obligation on the government, central government and state governments, to provide healthcare facilities, goods and services to the people in this country at affordable rates and accessible. So availability and accessibility. And in that, the government of India has singularly failed, as has been explained by others, and particularly to abandon and jettison the universal immunization program, which worked well. It relied on public procurement by the central government and distributing it through the states free of charge, resulting in equitable distribution, availability, and accessibility. The fact that they actually started off before the 1st of May, having a few for the private sector was not bad, but they were bent upon privatization of public health facilities. And that is the neoliberal agenda, if I can use that expression, if I understand you, Harsh, properly. That is the agenda which has led to the failure in terms of not only procurement, but also of distribution and making the vaccines available and accessible. But in the context of constitutional thinking, I want to add a point. Others have actually mentioned that they are jettisoned the rational and fairly well worked out successful policy. But why did it happen? The thing is, over a period of the last number of years, and particularly after the present government came in nearly 7 years ago, there has been usurpation of power in a few, and the constitutional imperative of rule of law, whereby all sections of government, whether it is ICMR or election commission, etc., they decide things what they are supposed to do, but they are not supposed to do things that they are not supposed to do. For example, ICMR should have been leading on the research front and persuading IGNOSOC to make sure that we are ahead of the curve in trying to track variants and then actually suitably responding to that. Instead of that, they were actually managing the pandemic, which has been noted by a number of writers. Who was deciding the policy in terms of responses? It was not the health ministry. The affidavit filed by the government of India in the suo motu petition on facilities relating to COVID, it's been very clearly and explicitly mentioned that the Prime Minister and the Home Minister are actually in charge of that. Now, that is understandable so far as the Prime Minister is concerned, because he is the head of the National Disaster Management Authority. But why should the Home Minister come in? There's no explanation. So the Health Minister actually had really no work to do in a health pandemic. And that is because, according to me, the rule of law has broken down. And that's why decisions are being taken not on the basis of science or rationality, but arbitrarily for certain other ulterior political and economic purposes. And that has been alluded to by Ramakumar also. It's very, and Sujatha ji also, that in India, why is it that even the Indian manufacturers, they are concentrated in terms of the platform, the technology platforms, and in terms of even of facilities? So why is it the Serum Institute of India alone, along with Bharat Biotech, are the only producers? There's no reason. Why should they not expand? As Sujatha ji has rightly mentioned, that there are public health facilities which are available, which are not being utilized. We could actually have done things much, much better. And let us not forget that India was the leading producers of vaccine before the pandemic. What is the position today? We are number 3. China is number 1 today. And it's sad to see, I must say, that the government policy has led to the pharmaceutical companies, which were actually on the vanguard. Sujatha ji will remember when at the turn of the millennium, the HIV crisis broke out, when drugs were sold at $10,000 to $15,000 per patient per annum. Cipla came out with a price of $750 or $350, and the prices crashed to $750. What is Cipla doing today? What are the other companies doing today? They are just importing vaccines and drugs and actually selling them at exorbitant prices, For example, tocilizumab is sold at 50,000 rupees. They are not actually manufacturing anything anymore. They are now actually in line with the big pharma, multinational pharmaceutical companies, and they are doing at their bidding. They have voluntary license regimes, which means that they do at their bidding. Why is this happen? Because the government has not created an environment for Indian generic industry to grow. Whereas, please appreciate and remember, in the 70s, when India was selling drugs at the highest prices, Mrs. Gandhi, I mean, I have a lot of problems with her emergency, but on this issue, I have to admire her because she changed the patent law and made sure that we actually give up patent protection for products and only protect the processes, as a result of which the Indian generic industry grew and we are able to afford the cheapest prices. But that's not going to happen because the environment is to privatize and make more and more profits, which is completely deleterious to the right to health. That is as far as the Indian situation is concerned in terms of the overall production of drugs and vaccines. But the zigzag, the 25% reservation, which even continues now, is to make sure that the companies make super profits. That has been said, I'm not going to repeat it. At the international level, just see and appreciate the fact that the US, which is a completely capitalist economy, took upon itself as the US government to procure drugs centrally and supply and make them available free of charge. In a pandemic, when a capitalist system responds like that, it is very difficult to understand why the government of India has not followed that. But there, it is important to remember and note that unlike in the normal situation where drugs, which are blockbuster drugs, which are made by big pharma, they claim, and it's not true, but they still claim that in order to produce a blockbuster drug which fetches $1 billion, in the first year, they spend $1 billion in what is called development costs. Now, in this case, the COVID scenario, they didn't spend a penny or a cent on development because by pre-purchase agreements, they got all the money to develop the drugs, the vaccines. But they made a huge profit. So, for example, Pfizer, the cost of actually development was about $2 billion, but in the first year itself in the pandemic, the turnover is $15 billion. So it's super profits, and super profits. That is the thing. And let me also add, the COVAX facility was never meant, as somebody has mentioned, was never meant to ensure equitable access. That was the dream of a few people there, but it was already controlled through the Gates Foundation. Let me be very explicit, which sits on all national, especially the middle and low income countries, on their government decision-making bodies, including India, as has come out in the affidavit, where they actually suggest the policy. They sit on COVAX, practically control it, and they also are in the pharmaceutical companies by way of large shareholdings. So they control the whole thing. And that is the tragedy. And they never meant to actually ensure there'll be equitable access. COVAX was only to make sure, if they ever got there, 20% of the populations in the low and middle income countries, that is the so-called vulnerable, not the whole population, unlike in the developed countries where the whole population was to be vaccinated. So the structure of COVAX itself, the goals were completely against equitable access and delivery. So I think the structure of the whole system is such that we were not going to make sure that people actually got the vaccines. So I think the main problem, and I'm situating it in the context of what you call the neoliberal economic structure, because it is particular type of capitalism which is actually being driven now, where the government has lost control over the health programs by privatizing it all over the world. But to the credit of the US government, they made sure that their people are vaccinated through public procurement centrally and making them available free of charge. Thank you.
Thank you so much, Anand. I think, although you came at the end, we were able to bring the strands together and also link all of this to the structure of neoliberalism and the advancement of private profit rather than the public good. We go into the second round. I request each of the speakers to speak for a slightly shorter span of maybe about 4 to 5 minutes. This is about solutions. We've understood both the extent of inequalities between and within nations, which are stunning. We've also seen the consequences of this. I mean, we're not going to get out of the cycles of illnesses, waves, lockdowns, economic slowdowns, and many other consequences, children's loss of education, and so on, until we are able to overcome these inequalities. What is it that needs to be done? I think is relatively clear. What should be done to persuade governments in India and in wealthy countries to recognize and act upon that maxim that no one is safe until everyone is safe. Once again, we'll concentrate first on the international. We'll have Gagandeep and Jayati. We'll speak about the national with Ramakumar and Sujatha Rao. And then we'll have Anand, who's somehow will bridge both of these. So over to you, Gagandeep, please.
So thank you very much. And I'd actually like to start by responding to the comments about COVAX. So I've been part of the WHO working group on COVID-19 vaccines. I've mentioned my association with CEPI previously. I've been an advisor to the Wellcome Trust and to the Gates Foundation. And I do this sitting at CMC Vellore and not being paid by any of them. So I will disagree with what he said about COVAX. And I'll take you back to the discussions on when COVAX was actually established. It was in April of 2020. And COVAX is just part of the Access to COVID-19 Tools Accelerator, which is about diagnostics, it's about drugs, and it's about vaccines. We did not know in April of 2020 that vaccines were going to succeed so quickly. We did not know that vaccines were going to work this well. I was part of the committee that drafted the target product profile for vaccines for SARS-CoV-2. And we thought we were being humongously ambitious in aiming for a vaccine that would do better than influenza vaccines. We thought respiratory virus, 50%, 60%, that's really good. The low bar of 50% was saying vaccines will be a useful public health tool if they perform at better than 50%. The 20% of the COVAX facility came from the WHO, very careful exercises done around the world trying to identify if we really want to protect public health systems, health care for people, and we want to protect the people who are most likely to die because of these vaccines, then how many people do we need to vaccinate? No one expected the stunning success that mRNA vaccines had been. In fact, now the discussion is around, should we be aiming for what we can do beyond the 20%? Because COVAX is a commitment to 92 countries for 20% of the supply. India is getting vaccines from COVAX, but is it possible for us to go up to 50% and 60%? I'm not part of COVAX, but I do hear these discussions from various other bodies. And to tar this with a brush that is everything is uniformly bad and everything is uniformly selfish, I don't think is appropriate. I'm not in favor of multinational companies, but I do want to call this much out about COVAX. Now, coming to global inequities, 1% of low and middle low-income country populations have received 1 dose. 25% of the world has received 1 dose of vaccine. That's inequity right there, and it is at a global level. And quite frankly, in a way, we are contributing to it because we are the ones that need the most vaccine. So if India vaccinates 22% of its population with 1 dose and 5% of its population with both doses, if we think on a global scale, then the vaccines that we are using are vaccines that were promised by our company to people in Africa that they have not yet received. Now, is that fair? Well, I think every country is out to protect its population. And there is, I think, lots of arguments for why everything that is produced in India should stay in India until we get to a certain point and then can offer our vaccines to the rest of the world. But what is that point? Will we behave like the US? Will we say that we want to vaccinate down to 12 years of age, that we want to have a stockpile of vaccines that can be used as boosters? I think that is where we need to have a clear view to where our policy is going. Right now, of course, we have no idea about what will happen next month, let alone what will happen once we've vaccinated a significant proportion of our population. So I'll stop there and maybe respond to questions later.
Thank you, Gagandeep. I think that the uncertainty that you also speak about is crucial, but that India's policies actually, though we are a middle-income country, reflect the same inequities in our attitude globally and in our actions globally as they reflected internally. Jayati, a little bit towards solutions. Are we stuck with this reality of inequality between nations? Is there something still at this stage that you see happening that can correct it?
Yeah, thank you. So first of all, I want to clarify what I said about COVAX, and I'm fairly sure that there is nobody in this panel that is saying that COVAX is terrible or anything. In fact, the principles on which COVAX was based are excellent. The principles on which the vaccines were to be shared are also excellent. The first 3%, then 20%, and so on. So all of that is absolutely fine. I think the problem, at least for some of us, came about because of the fact that it is hugely underfunded, which has been repeated over and over again, and that it is actually something that enabled the vaccine grabs because it didn't, of course you could argue, can COVAX prevent governments from doing their individual side deals? But that there was possibly at that stage even no idea that governments would go and do the side deals and therefore prevent COVAX from being able to buy enough to do the initial vaccinations that were promised. I think that is something that is raised in general. Okay, solutions. Once again, I'm focusing on global. Why? Because, I've noticed there are comments in the chat and in the questions that it's all fine to talk about the global, but the real problem in India is that the Indian government is at fault. And I'm not disagreeing with that. But I do believe, as Gagandeep just mentioned, that you can't, even as an Indian, say we don't care about the rest of the world. And that's a bit like, exactly what the countries of the North are doing. We're all right and we don't really care what happens everywhere else. And it doesn't work. We know that. So it's absolutely essential for us to be focused on how we can ensure global distribution, equitable, universal global distribution as soon as possible. Yes, it is remarkable that we have these vaccines as quickly as we do, but now that we do, it is obviously in everyone's interest to make sure that they get across to everyone in the world as soon as possible to prevent this pandemic from continuing in the way that it is. So in the WHO Council, we've actually submitted a paper on innovations, health innovations, specifically with regard to COVID-19, in which, with regard to vaccines, we have mentioned 5 major areas in which we have to do something. First, I suppose you could call it vaccine solidarity, that we should redistribute the available vaccine doses from the stockpiles of the countries that have vaccinated more than 20% of their population, with a significant proportion of doses to COVAX. G7 promised to distribute only less than 1/5 of the stockpile that it currently holds, and that too by the end of the year, whereas it could be done immediately. So we really need a much larger redistribution of the available vaccine doses. Second, in the area of knowledge governance, obviously you have to waive the intellectual property rights for all of the medical technologies related to COVID-19. During the pandemic, the TRIPS agreement specifically allows for this. It says exceptional circumstances warrant the waiving of IP, and that refers not just to vaccines, but diagnostics and therapeutics and all of these things. This, as I mentioned, is really only about the legal constraints to increasing the supply. Third is technology transfer. We really have to compel vaccine producing companies to share knowledge and transfer technology. Remember, this doesn't mean that they're giving it for free. You still give them some royalties, reasonable royalties. But there must be, and particularly for vaccines whose development benefited from public funds and public research, there must be an insistence on sharing this technology. The fourth is the issue of supply chain resilience, which I've already mentioned, that we really have to ensure the production and wider distribution of all raw materials and intermediate goods required for production of vaccines and therapies. And then there's manufacturing resilience. We need to expand manufacturing capacity in all the regions. In Africa, there are already discussions about creating vaccine production facilities because they have realized how much they have suffered because of this absence of regional facilities. And so this is all, of course, relevant right now, but it's part of an end-to-end pandemic preparedness. This is not going to be the last pandemic, and we're going to get more and more of these. So ideally, we should really have global public health infrastructure that includes global public production and globally distributed, ready-to-use manufacturing capability. So there is a strong case made here for not just publicly controlled and subsidized, but public production and distribution of the vaccines.
Jayati, that's really powerful, a powerful imagination. I think that we really need to push for it. How quickly we would be able to unfold that for the present pandemic would still remain a question. And when you come back, but that we have to prepare in the medium run for more such impending catastrophes is also true. We'll shift our focus to India with the next two speakers. Ramakumar, quick comment on solutions, and then Sujatha, of course, with her policy experience.
Thank you, Harsh. I'm sure Ms. Sujatha Rao will be able to add much more than I can, because she comes from the system and she has enormous experience on how we can, on war footing, address this kind of a challenge we are facing now. To begin with, what we have done till now is to encourage a certain vulgar form of predatory capitalism with respect to vaccines, where the impacts of both an incompetent state and a very iniquitous market for vaccines, quote unquote market, are out in place. They are completely visible for everybody, and this is the most important problem. What should be done is the question that you have asked. I think there are questions with respect to production on the one hand, and there are questions with respect to distribution on the other hand. They have to be taken separately. What is to be done with respect to production? We have to change what we have been doing, in the sense that we did not make any investments in the past. We did not invest adequately in R&D. We did not invest adequately in capacity expansion. Change it. We have to invest heavily and quickly in giving more companies licenses, giving more, investing in both public and private sector with respect to capacity expansion. All this have to be done over the next few weeks, if not months. In fact, we don't have time. In fact, how to do this quickly? We have done enough damage to a vaccine policy by simply not doing anything for a long time. We have to undo it. We have to do it quickly, and also produce on a mass scale. That's very important. Identify all the public sector vaccine companies which can engage themselves in vaccine production, invest in capacity, invest in laboratories which have to be repurposed on a war footing, give them licenses to produce, and so on and so forth. All these have to be done on the one hand. And wherever compulsory licensing or other instruments have to be used, we have to use that. I'm sure Ms. Rao will be able to say things more authoritatively there. The second is with respect to distribution and acceptance. With respect to distribution, it's very clear that currently we have an iniquitous vaccine regime which has to be completely overhauled. Simple tweaking of 50-25-25 into 75-25 and all won't work. To begin with, the central government will have to take over 100% of the procurement at a regulated price. Central government cannot pay 1,380 rupees for a vaccine for which it shares the IPR with a private company and then give it to people for free. That would be extraordinarily perverse in design, a policy. That cannot happen in a democratic country like India. 100% procurement at a regulated price, which provides a normal profit to the manufacturer. That should be the guiding principle in vaccine procurement of the central government. Second is that you need to take a number of steps to ensure that vaccine acceptance or rather vaccine hesitancy become a problem when you reach, say, 30, 40 or 45% of your coverage. You have to probably prepare for that from now itself. For that, one of the most important things required is an open attitude to science. You cannot have a vaccine policy where a vaccine like Covaxin is there, where the government has contributed considerably through its laboratories, ICMR and CSIR, where a prime minister or the ICMR chief says in July July 2020 that when phase 1 trials are going on, you say that by August 15th of next month the vaccine should be out, and it has the approval of the highest authority in the government and so on. You literally threaten a company. Keep a gun on their head and say that you have to produce a vaccine which is in phase 1 to produce by a month's time from there. All this has fed into enormous amount of vaccine hesitancy also, apart from the already existing vaccine hesitancy in the country in large parts. Now, this open attitude to science, transparent communication is extremely important. Positivity is a bad word in these times. If you have a bad news to give, you learn from the Kerala Chief Minister, who opens a press conference by giving the worst news of the day, not the best news of the day. He opens a press conference by giving the worst news of the day, and that gives him enormous amount of credibility as a communicator of policy. And that's precisely something that the government of India should learn from. And that's where communication is extremely important. Transparency is extremely important. Open attitude to science is extremely important. And that's with respect to acceptance and hesitancy. Vaccination centers should be overlooked. The affidavit of the government says that 75% of the vaccination centers are in rural areas, but only 56% of the vaccine doses are given in rural areas. So very clearly, there's a rural-urban divide that very clearly comes out. You have to address this. And I'm sure others can contribute more to this topic, but basically more autonomy to states in terms of how to conduct vaccination is extremely important. Door to door, we have to experiment with it. Clusters near residential apartments or residential clusters, you will have to experiment with them. All these have to be done in the next few weeks or months, particularly because we are soon going to hit a stage where vaccine hesitancy is going to be a problem. The last point I want to say is with respect to the CoWIN platform. Now, CoWIN has been a disaster, which is very clear for all of us. And basically, if you see, 59% of the beneficiaries registered have come in through a walk-in mode, and 78% of the vaccines doses administered have been on-site. That means they have not been given appointments through COVID. This is the government's admission through the second affidavit given to the Supreme Court. Only 1.5 lakh people were vaccinated without an ID card, and 39 lakh people were vaccinated through near to home vaccination centers. These are interesting ideas. Why are we not pursuing them? Near to home vaccination centers, where are they? I haven't seen any in the city that I live. So we have to do a lot of things with this COVID. This is an Aadhaar hangover basically that we have today. COVID has to be set aside. Access has to be more transparent and democratic by allowing for walk-in registrations on a mass scale, and thus basically we have to improve access to vaccines for larger sections of our population. Now, this is not an exhaustive list. I'm sure others can add, but these are a few important things that come to my mind that I can speak on in the little time that was provided to me. Thank you.
Thank you so much, Ramakumar. I think that was you're saying not an exhaustive list, but a very impressive list. And I wish government would listen. We turn now to Sujatha Rao. Assume you were Health Secretary. I wish you were today. What would you advise the government to do?
Well, to begin with, I think the first policy that the government has to take, and I know it won't, is to centralize the total procurement. This 25% business is just not only that you're enabling profiteering, but more importantly, there'll be huge amount of siphoning, huge amount of black marketing, huge amount of, in the rural areas where people don't know what is free, what is not free. Our friends, the government doctors, all own nursing homes of their own. They're going to take away our free vaccines and sell them at whatever rates they fancy and make money there. I mean, this may not even come in your media and all that, because the media's, God knows what they do. But the point is that, ultimately the poor people will suffer. I know for a fact, because I'm engaged with some people in UP, for example, at that time, before May 1st, people were told, "Nene, 250 rupees dene vaccine ke liye." Now they know that in the private sector it's 250, so they thought even government may be 250 here. So they were all paying the 250 and they were getting the vaccination. So as I said, okay, 250 is something, but to be asked to pay 1,500 and all that, of course, those who are black marketing and siphoning may not charge that much. They may be less greedy and charge 500 rupees. But whatever it is, the free vaccination program can get a hit. And I think this kind of differential, where it's free on the one hand and 800 and 1,500 on the other hand, is making 2-3 parallel systems very, very difficult to administer. It's a nightmare for a government officer, let me tell you, to say who's doing what. And secondly, the private sector is also procuring by raising the intent through COVID. The district collector and the people there may not be fully aware how much Apollo is getting, for example, where they are providing the vaccination, so to see that I don't duplicate and we both supplement our energies. So this kind of planning there can be difficulties. And I know these private sector people charge not 150, but they charge more if you do outside camps, outside the hospital camps, saying it costs them much more and so on. So I think this whole thing, this policy must be taken back, and 100% procurement must be done. And ideally it should be free for everybody so that this problem is resolved. But I would say that even in our universal immunization program today, as we stand, we do procure for every child and we do provide it free of cost. But the private sector can very well also offer a polio vaccination for a child and charge them. But that's a different game. If I want to go to Apollo and pay for it, that's my wish. But if I don't want to, I can go to the government facility and get it free of cost as well. So I think dual pricing already exists, but not like the way it is being, the prices have been given by the government. How can you have an administered pricing of this scale? I don't understand that. So I think this is one policy that should go. The second is that, I could, within the country itself, of course, the Covaxin, I think, has failed on its own. We don't have to do very much to make it fail worse. But, I think I would like to go, though you're asking me to talk about India, but I think the global failure has been much more intense. in dragging its feet and not declaring a patent waiver for COVID vaccine and COVID-related products. I think that's a huge failure of global leadership, and I think that's where we are getting badly hurt in the process. So I really feel that I think global leadership has to come back strongly to say that vaccine is a public good, and we have to reset the entire dialogue of vaccine in the public good category and make it free. But can be or not, I don't know. Finally, I would like to say that government has to invest a lot more on sprucing up their public laboratories, which, even in this 23,000 bonanza, which they released recently, I didn't see a mention of. If I'm wrong, I stand corrected, but I didn't see any investments being directed to see that our public manufacturing facilities are spruced up. Though I do know that ILI, Bibicol, and Hafkin are being provided assistance to be able to manufacture COVID vaccines. But we have other manufacturing concerns. We have, as I said, Chingalpat is all there ready. I think we should really invest much more in ensuring that vaccine comes back into the public sector fold. I think that's very important as an equity principle. Thank you.
Thank you so much, Sujatha. Both doing away with the 25% for the private sector and bringing back the public sector centrally into production of vaccines very important, and of course mediating globally with for a patent waiver. Anand, we're running short, but we'd like to hear your views advancing the right to health both in India and outside, and then we'll go in for the questions as the last round.
Yeah, Harsh, I'll be very short. I agree generally with what Ramakumar and Sujatha said. There's absolutely no dispute on the public health point of view about what is to be done in India in terms of procurement. In terms of production, everybody agrees there should be an increase in the number of facilities, and there's a cornering of that within the two Indian producers. So there has to be diffusion, increase of production facilities, and diffusion of technology. Now, one is relying on the traditional technology, which is actually more difficult to administer than the new technology, which is a purely chemical technology, the mRNA. So we have to think of the future. And there, not only public health facilities, but even private facilities can be encouraged. The thing is, my discussion with private generic producers is that they are not, the environment in India is not friendly for them to produce in India. Even Sujatha ji will agree with me that Cipla had to give up pediatric HIV treatment because they were just not able to recover the money that they were supposed to be given. They just gave up. So there is no encouragement for generic producers in India for producing in India. That's why they're going abroad. There are other reasons also. So I think there has to be properly formulated policy for encouraging generic producers, both for drugs and vaccines and diagnostics also. Now, on the COVAX, I am very happy, as Jayati said, with the objectives. But I think there's a structural problem, which I'm sorry, I did not actually make myself clear. And I have the highest regard for Dr. Kang because of her brilliant work and what she said even today. But I think there's a structural problem in thinking that COVAX, please appreciate that, they limited their distribution to the developing countries to 20%. I asked the question, why 20%? The figure is set. And secondly, did they really expect that they would actually get money from all the developed countries when in a pandemic history has shown they don't do it? And that is now more than evident in the TRIPS waiver. I'm only saying, let's be cautious. I think the altruistic ideas are good, but altruism cannot take the place of reality. And let's remember, in today's world, it is profit which drives everything. And that's why it's the reality. I have seen it myself. I have interacted with Gates. I was on their Karwan Foundation. I've seen that everybody wants to make more and more money. While people are dying without food, these people are happily making so much money. I think the reality is so stark that we were foolish to think that it would work. I'm not saying you should not try it. I actually commend Dr. Kang for, putting her best foot forward and making sure that her ideas are put forward in the way they actually articulate the best possible outcome. But I'm realistic. I've seen things don't work. Anyway, finally, I think I feel very strongly that our institutions, and this is actually in response to what there's on the chat box, I think the institutions have failed. There's a breakdown of rule of law in India for the last decade or so, even before the dispensation today came into power. But it has been actually perfected. The decisions are taken by a very small group of people, not on the basis of rationality and science, but on the basis of other extraneous circumstances and reasons and motives. And therefore, you have limiting of production facilities in Serum Institute and Bharat Biotech. I'm not going to say more than that. There's an abject failure in devising a proper, rational, workable policy. And the sad thing is that when a policy has worked from 1978, the universal immunization program, why should you actually change it? What is the reason? And there's absolutely no reason. And that's why the Supreme Court says, prima facie, it is arbitrary, irrational, and actually would promote the divide, not only between rural and urban, but the digital divide. And that has been noted. So I'm not repeating it. But we can change. We can definitely change. And I think what people have articulated are the first thing on actually procurement. There's no dispute which way we have to go. But on production, we have to be more firm and diffuse the technology and production facilities. And finally, on licensing, unfortunately, the government is opposing compulsory licensing. We have articulated in the suo motu petition in the Supreme Court that compulsory licensing not only for patents, but also for trade secrets. There are a number of other things that come with it, which actually block the production. They have to be made available. And the government is actually opposing it, not only in the case of COVID, but even in TB. They have a policy of opposing it. And the sad thing is that they used to oppose it because the USTR, the trade representative of the US government, used to be opposed to it. Now, and it's not an accident, because amongst the Democratic Party in the US, the base of the Democratic Party is completely changed. They are articulating a program which is much, much more radical. That's why you see a change in the position of the US government and the USTR in the TRIPS waiver issue. And I think in order to change that, we should pressurize the US government, and I think we can do it, having allies in the Democratic Party who can push the government of the US to actually change even more radically, and they would not insist only limiting the TRIPS waiver to the patent technologies, but go much, much further. And I think we can do it. We can still become the first in vaccine production, provided we actually go for that and not rely only on privatization. Thank you.
Thank you so much, Anand, for reminding us both about the importance of production and licensing, and also that the US administration today has gone on a much more radical direction than many of the countries in the developing world.
Harsh, I just have a comment to make, if I may, before you. Is that see, even if let us assume that this present government is interested in private sector, promoting private sector as its ideological base, it may have so, that's their problem. But even there, after all, somebody who believes in private sector must also believe in competition, right? And here, I don't understand why they are dragging their feet when it comes to any competitor to Serum and Bharat Biotech, as by way of an example. And my information only comes not from being a member, I'm not a member of any committees, but from media. And here Cipla had very clearly said, for example, that Moderna is willing to do technology transfer and give me give us their technology, provided we give that waiver of indemnity and so on. And Cipla also made a commitment saying that in that case, they are willing to make $1 billion investment in setting up the vaccine production of the Moderna vaccine. Now, why after that we never heard any further? Of course, now the government has given that indemnity waiver to Moderna, which is going to supply some few vaccines. I don't know how many, maybe 2-3 lakh doses or something like that. I don't know. Not a very large amount of vaccines free of cost as a gift through Cipla. But that's not what should be our problem. We are not interested in those little chickpeas of gifts. What we want is production. So why is Cipla not being told? Why did we not say, we'll give you indemnity, we'll give you all these waivers, provided you give us the technology transfer and have one of our two of our companies being able to manufacture? Then we would have developed our own manufacturing capability. What happened to our negotiating skills there? And definitely I'm told, and Dr. Gagandeep can really clarify further, but I'm told from my other virology friends that mRNA, all that are much more advanced vaccines to what Bharat Biotech is giving, which is a 100-year-old platform perhaps. So, if we are able to scientifically also advance in this whole business, that's a good thing. But we are not using our negotiation. I don't know what happened to that deal. So I just feel that this is a moment that the government of India had to try and give away waivers if required, provided this technology transfer. The problem with Pfizer, which I also faced as secretary during H1N1, but I didn't take so long to say no to them. I took barely 24 hours. And that was when they wanted indemnity. And we said, no way, you're not getting any indemnity from us. And we said, we don't want your vaccine. So, but then that was then. It was not such a serious issue as the COVID thing is. But Pfizer doesn't make a technology transfer offer. So I think in all this, somewhere, something else is happening which we are not able to understand.
Yes, Sujatha, I mean, that the state is clearly promoting monopoly through its policies.
That's what I'm trying to say.
At a time when we should be,
I mean, the Reddies are not allowed to do phase 3 for some Sputnik, something that they wanted to do. They're not given the permission. I mean, I don't understand the selectivity that's kind of going on. And, so it's not even pure capitalism that we are seeing through this government. What we're seeing is oligopolism, if there is any word like that. So, which is not a healthy thing, because we had a very vibrant vaccine producing base. And I don't really care if it is private sector also. But if public sector is also there, you get at incredibly low cost. You get the vaccines. We've benefited a great deal with this kind of competitive environment.
Thank you. I hand over now for the last part to Navsharan. I request my colleague to hold any questions and take the last closing remarks from all of you.
Thank you, Harsh. And thank you to our panelists for a brilliant discussion. I think we've learned a lot, and biggest takeaway and no prizes for guessing is that within a neoliberal order, we are dealing with an architecture of unfairness, both at the global level and also in India. And I think there are a few questions in the chat box, and I think they are actually on 2 counts. One is to look at asking us on the question of the global architecture and how countries can cooperate to build better and to dismantle that kind of, or dislodge those who have pushed the way in front of the queue because of their access to resources and power, and what can be done. So let's take the first round on the global architecture of unfairness, and what choice do countries or smaller or poorer countries have to cooperate or to enter enter the queue on some strong footing. So that would be good to get this comment. Yes, Dr. Kang first.
So Navsharan, I'm really sorry, but I have to leave in a couple of minutes. But
Okay.
I'd like to leave you with the idea of what the African Union is doing.
Mm-hmm.
I think they have been affected so badly in this pandemic that they have come together to say that we need to be thinking about vaccine security for ourselves. And while we still rely on the rest of the world, the COVAX facility included, for a portion of the supply that we need, ultimately we are going to need to buy or make our own vaccine. So with the African Union, with the engagement of the African CDC, they have begun negotiations with vaccine companies around the world, including Indian vaccine companies, to look at locating manufacturing facilities that can be ready to make vaccines for Africa. So one facility, South Africa had only one company that really made vaccines. Now they have two companies that are going to be engaged in vaccine manufacture. Tanzania, Kenya, a number of countries are now looking at, can they establish capacity? So I'm actually very impressed with what Africa is doing on many fronts that are related to surveillance, to testing, to trying to build their own cadre of scientists. And what I'm even more impressed by is the fact that the African Union, with all of its problems, which are much more than ours in some senses, that they're actually coming together around health, around capacity building that relates to health and health products. So I think we have global examples that are
a regional alliance,
yes.
Also to deal with. Yes, Jayati.
Yeah, thank you very much. I'm so glad that Gagandeep Kang raised the example of Africa, because it is absolutely the case that there is much more interesting cooperation happening in the African region than in other parts of the developing world, certainly South Asia. But also, I just want to highlight the importance of China, which so far is the elephant in the room. More than half of the vaccines distributed globally are from China. Let's not forget that. Yes, it's true that Sinopharm and Sinovac are less effective with the mutant varieties, but they're not ineffective. In fact, I think going by what was being suggested earlier, 50% plus, they are certainly an important counter to the spread of the disease. China has already entered into agreements, production sharing agreements and production facility creating agreements with a number of developing countries in Latin America, in Africa, in Asia. And I think it's going to play a bigger and bigger role. There are those who believe that the Biden administration's agreement to stop opposing the TRIPS waiver was not just due to public pressure, but also because of the fear of Chinese influence expanding because of this. I think we should welcome this. I think we should welcome all alternatives and all alternative knowledge that enables more. Similarly, there is significant advance in two vaccines from Cuba, one of which is in the phase 3 trial stage and the other one which has already shown a lot of promise. The initial phase 3 trials of the Cuban vaccine are showing relatively impressive rates. So I think it's in excess of 90%. And so there is a lot of hope also from the Cuban vaccines. Once again, they already have production and knowledge sharing agreements with a number of Latin American countries. So there is, what will happen, I think, is that this, what you can only call sort of immense neo-colonial betrayal of the advanced countries is going to have an impact on what developing countries do. I think in the neo-colonial betrayal, we should also add the Indian betrayal, because we cannot absolve ourselves of the fact that having made commitments to COVAX and having got technology on the basis of a certain distribution of vaccines globally, we then reneged on that commitment. That is at least how the rest of the world sees it. And yes, it's true, and it reflects entirely the failure of the Modi government in managing the whole vaccine policy. But that globally, this is seen also as that you cannot be relied on. So I think we're going to see much more of this diversification, and decentralization of production, which is greatly to be welcomed, I believe. Because as I mentioned, one of the things that we had recommended is precisely that you actually enable much more global production and distribution, which encourages greater resilience within regions as well. Of course, issues of equitable distribution remain, and those are also sharp in all of these countries that we have mentioned, other than Cuba and so on. But there are issues internally. But in terms of the global, I think it's going to happen, independent of even what WHO may recommend or anybody else may recommend, or even what the WTO allows. It's going to happen because countries now realize that the very survival and resilience of their societies and economies is dependent on a greater degree of, shall we say, domestic production.
Yeah, absolutely. Thanks, Jayati. Anand, would you like to come in now?
Yes, I think we have made a huge number of mistakes, not only locally, but in terms of our responsibility, not only contractual, but otherwise also towards the developing world. And I've seen this not only now, it's happened even before. For example, in Uganda, CIPLA actually had to set up a drug facility. China only had a hospital, but the Chinese were very good actually making sure that the hospital was known to everybody, whereas the drug facility, which was producing ARVs at a very cheap rate, there was absolutely no messages going out showing what India had done. And that's the failure of the Indian government internationally, I think. Even on the TRIPS waiver, we are not the active ones. It's actually South Africa. But we can change it. I think we should go back to the drawing board. First of all, we have to increase our production facilities in India to ensure that it goes through COVAX and even bilaterally to all developing countries in Latin America, in Africa, and other countries in Asia. Till today, in Latin America and Africa and some parts of Asia, for ARVs, they are dependent on Indian drug companies. And we actually use, the problem is that the environment for generic companies is not conducive to develop vaccines and promote them to export them to the developing countries anymore. That environment has to change. My talks with people in the generic industry, I represent some of them in the patent oppositions. They say we cannot survive the way that we are actually forced to, not only domestically. Domestically, there's no incentive for them to produce. And there's a big kind of debate between the civil society advocates and the generic industries, which I think should take place in terms of pricing. The quality is assured, but in terms of pricing. But in terms of exports, if we want to maintain our leadership position in drugs and also in vaccines, we really have to encourage, and like Ramakumar has mentioned, diffusion of technology in other production facilities, private and public, so that we are not reliant only on two, because we were reliant only on two when the actual, and because they did not anticipate the second wave. When the crunch came, Serum Institute had no choice but to restrict its distribution to India. That was the failure because we didn't have enough production facilities. So if SSI failed, we could have relied on other facilities to honor our commitments to COVAX facility. And I think the government should ensure that when, say, CIPLA or any other company goes to Latin America to set up a production facility, they should be helped. And it's very difficult to survive, by the way. When say, for example, South Africa will have a facility in South Africa, they'll be producing vaccine at a very higher price compared to, say, a company like Pfizer. They are actually selling in Europe and America at $2. We are selling them at a higher price today in India. So that's what's happened. We should actually produce drugs and vaccines at the lowest price, which we have the ability to do. But it's now in reverse gear, not only in terms of universal procurement, but also encouraging the drug and vaccine companies to produce them at a high level and cheaply. That's what has to be encouraged. There should be a mass of production which is available domestically and for exports. You just have to change a very, very, very little changes are required. Encouragement or pre-purchases. Why did they not pre-purchase from November? They could have easily done that. Serum Institute would not have been in a problem. But we thought we had actually conquered and vanquished COVID-19 because of our strange, unique culture, whatever. And we didn't do anything. Now we have to go back. Now there is a need to make sure that we actually encourage our industry, both public and private, so that we become the largest producers. And it is very easily possible of both drugs and vaccines for COVID and any other pandemic that may occur.
Thanks. Thank you, Anand. And Ramakumar, I'm going to come to you and also ask you to, if you can, there's another question in our chat box about US politics and whether it's going to have an impact on their technology transfer issue, the new presidency and all, if you could integrate this question also. There's also a second set of questions about 3-4 questions about domestic policy choices where we failed miserably, and how do we explain that? I mean, a lot of it has been said, but your final thoughts on integrating these questions.
Yeah, sure. That's sure. Look, I would like to close my points with a very different, at a very different pitch, which is what is going to happen from here to December, and what is the culmination of all this, and what's going to happen till December. There are two sets of claims which the government makes. First set, which has made the second affidavit to the Supreme Court also, is that India will administer close to 51.6 crore doses by July end. That is one statement made in the affidavit. There's absolutely no way that's going to be possible, because by end of June, we had administered about 33 crore doses. That means we were hoping to administer 18 crore doses in the month of July, where the government itself in another appendix or annexure to the same affidavit had said we'll be able to do only 12 crore doses in July. Now, even that 12 crore is doubtful, because the blitzkrieg that you saw in the first week of the June 21st policy shift, where we went up to 88 lakh doses on the first day, and then 67, 65 on the third and fourth days, and so on. That period is over. They had stockpiled doses for that particular blitzkrieg to showcase it as a spectacle in front of the people, as a new policy, which was a huge success. But after 28th of June, that kind of pace has been impossible to replicate. In fact, over the last 7 days, our vaccination rate is a pathetic 34 lakh doses per day on an average. So that's the rate. So simply we don't produce that much. Our production is close to 10 crore to 11 crore doses per month at the maximum, not more than that. Rest all you have to pull out from stockpiles and so on. So that continues to be a key constraint. I do not see more than 44 to 45 crore doses being administered by the end of July. Second point is what's happening between August and December. The first bombastic claim made by the central government was they're going to have 2 billion doses produced or to be made available between August and December. That's close to about 215 crore doses. Now, in a month or two, that was downscaled drastically. Now, the new affidavit, if you see, they place it not at 215 crore or 2 billion, but at 135 crore only. Many vaccines which were listed in the first claim, that is, for example, Novavax, Genova, Bharat Biotech's nasal vaccine, all of them are out. They're not going to be available by December. Only a few Sputnik and Covovax and Zydus are going to be available. But there again, the numbers cited are very high. In fact, Covaxin and produced by BB is the biggest failure in this whole story. What did Krishna Ella say in January? I think he needs a short crash course in being in humility, realism, may I say. Because in January he claimed that in the year 2021 his company is going to produce 70 crore doses of Covaxin. This is his public statement in January, apart from the bottle of water claim that he made with respect to prices. Now, how much has he given till now to the country? Only 5 crore. Where is 70 crore? Where is 5 crore? right? There's simply there's a huge difference between what that company claims as its capacity, or it's going to be its capacity, how much it's going to invest, and so on, and finally what it delivers to the market. That cannot happen in this country. Even here, by December, they're claiming that 50 crore doses of Covaxin will be available. From 5 crore, you're going to jump to 50 crore in a matter of few months. That's simply going to be impossible. In my view, you require about 195 crore doses to vaccinate everybody above the age of 18. You will not be vaccinating more than 100 or 120 crore doses by December of 2021. By the time hesitancy would set in a little bit, and you are basically going to take the whole of 2022 to cover the rest of the population above the age of 18. By the time a vaccine would be developed for those less than 18 years of age also, where will that be produced? How much of that capacity do we have? Is there any discussion happening on producing those now? No. Just as we had no discussion or only talk and no action in 2020, there's going to be a lot of talk and no action on children's vaccines in 21 also. Where is the capacity for children's vaccines for COVID-19 going to come from? Where is the investment? Where is the capacity? Simply no answer. So it's going to be, the future is very bleak in my view. Past policy failures have taken their toll, but we don't appear to be in a mood to correct it also in the short run. The continuation of those errors means that we are not going to reach anywhere, even in 2022 also. That's bad for the world because Indians are very, very mobile. They travel to different parts of the world. They'll take this virus to different parts of the world. It'll mutate, and then booster dose will be required, which will require additional production capacities. Now, I don't want to make it bleaker than this, but the unfortunate situation is that future is indeed bleak.
Thank you, Ramakumar. And finally, your final thoughts, Sujatha ji. And also, if you could tell us, apart from the policy failure, what kind of pressures would work on a state to actually to act? How do we build our campaigns? How do we seek accountability for the massive failures that we have encountered in terms of our policy? But your final thoughts.
I don't think, the way Brazil had thousands of people on the road asking for free vaccination, those kind of mass movements, I don't see any signs of it in this country taking place. So that's out. Our opposition has shown how incompetent they are by not even being able to get a parliament standing committee to review this whole vaccine policy. I mean, they're just an appalling lot of opposition leaders that really disappointed me a great deal. So the only mantra that seems to really have some impact on government is the Supreme Court. And it is, if the government has changed its foolish policy of liberalized vaccine procurement to a more slightly better version, 75-25 on May 7th, is largely because they were expecting something from the Supreme Court to say, you can't have this kind of 50-25-25 kind of formula. And to preempt that, I think they really brought that policy change, not from anything else. And what worries me is that this government is totally political, like all governments are political, but there are time comes in history when you expect your political leaders to take that little leap into a bit of idealism and work on principles rather than just only your own self-interest and your politics. And I don't see much of that happening either. Now, why I say opposition has failed is, of course, the Kerala Chief Minister tried to get all the chief ministers to write and all at that time. But, I don't think that suo motu petition, we could get all the governments to file affidavits, the opposition governments to file affidavits in the Supreme Court saying that we want this policy change. So that's how bad our opposition is. What the calculations are, what the fears are, God alone knows. So in this kind of environment, government really has a lot of freedom to do whatever it wants. And the only thing is, if another second wave type of event takes place again, God forbid, but if it does, then the likelihood of them losing the UP election, I mean, there again is a political calculation. Not that 1 million more people, Indians, have died, but it is that they may lose the UP election, will probably bring a better policy mix into it. I'm sorry it is so cynical as that, but that's where we seem to be. Because I honestly don't understand. I have worked in that Nirman Bhavan not for 1 day or 2 days. I've been in that building for 15 years. I have seen public policy right from director, I've climbed up the ladder, director, joint secretary. I mean, every post that there is open for an IAS officer I've held. So I've seen policy, I've seen politicians, I've seen how policy making is done. But this beats me. This kind of a response to COVID, which has completely destroyed India economically, socially, psychologically. Look what's happening on the education field, a whole generation of children. You can't think of a worse crisis than this. I mean, the Indo-China war is nothing compared to what we have faced through COVID. And still our policy response is so confused and so strange, is something that I am unable to really answer. So I'm just praying that, since we have 330 million gods, that at least one will take some compassion and put some better sense in our leaders, and God intervenes and tells them that please do proper procurement and have a more rational policy to it. I personally feel that the public sector, the production side, is where we are failing. And, I have no objection to a private sector manufacturing vaccines either. I don't think we can put the reverse engineering that is easy in drugs. It's not so easy in vaccines. Vaccine production is a bit more complicated, requires a far more technical expertise than a drug would. A drug, you can break it down to its last elements and bring it back again. Vaccine is not that easy. So I think we should respect the science behind it, but does not make it impossible for state government, for the country to really bring back its frontier position by encouraging private sector and building up our own public sector capacity in vaccine production. I think that's where we are failing, and I just hope good sense prevails and we put in the money that's required and give that policy environment.
Yeah. Oh, thank you, Sujatha. Thank you. And I don't think we are ending on a pessimistic or a cynical note. I mean, even when the situation looks bleak, I think in the discussion also there are a range of possibilities. And for people who are in the public domain, activists, there's much to learn from, lessons which are emerging from other countries, and also the choice.
But Navsharan, I'd like to just interrupt you on one small point. I'm not so sure I agree with Ramakumar when he says that end of December we'll still be muddling around for supplies. I have a feeling that we'll have a much wider choice of vaccines. Zydus is definitely going to come up, both with the child vaccine and its DNA vaccine. It's almost through. I think Novavax will definitely come in also. The nasal spray, I think they're doing the first and second phase, and the third phase should be possible. And that may, so I have a feeling by December end, I'm not talking in terms of production, but certainly clearances for a wider array of menu of a bouquet of vaccines will be available. And in the public sector, all the three, immunologicals, Hafkin and Biblicor, will get into a production space by September, October, and they'll together add maybe 10 crore vaccines to the kitty. So we'll be in a better position definitely by December. But I have a feeling, given the challenging environment in which we are, that even by May, June, if we can get the first dose through to all our population, it's still, I think it's a very good record. I mean, it's not a joke, I mean, right now we've done some 375 crore people covered. It's not a small matter. I think we need to be a little bit, pat ourselves a little bit here. Of course, when you look at percentages, 7% and all that, yes. But, in terms of absolute numbers, they have done a decent job considering we've muddled up the supply side.
Thank you.
But because this 75% doesn't make sense to me, Ramakumar, because I don't know what the denominator is. If Dr. Harshvardhan says 12 crores will be available to you, that means 16 crores is being manufactured. So where is the remaining 4 crores going? Surely the private sector cannot disburse 4 crores. And when this is the position, how is Bharat Biotech getting into agreements with Brazil to supply 20 million doses? From where is that coming? So, there's so many contradictions and lack of clarity in this whole story that I don't even think we can get into it, because we'll just get so confused that we won't be able to sleep tonight.
Well, fascinating discussion, and some of us still don't want to leave, although we have come to the end of our webinar time. So thank you very much once again, and I'm going to invite my colleague Sagar to say the last few words, and with that we close the webinar. Thanks all, and over to Sagar.
Good evening, everyone. On behalf of Center for Equity Studies, I would like to thank our respected speakers for sharing their knowledge and opinions on a very special, and important issue. And thanks to our moderators. Also, thanks to our partner Rosa Luxembourg Stiftung and media partner Newsclick for their support. And thanks to all the audience for their presence and attention. Stay safe, stay healthy.